Hello, good morning. Very glad that you can join us today. Our first speaker for Symposium 4 on optimizing perioperative care is Professor Declan G. Murphy. Professor Murphy is a consultant urologist and director of genitourinary oncology at Peter MacCallum Cancer Centre, Melbourne. He's also a professorial fellow at the University of Melbourne and a founding director of Cancer Specialist. Professor Declan is an internationally recognized key opinion leader in GU oncology, prostate cancer, and has published hundreds of peer-reviewed papers. He has also been a chief investigator on competitive GU oncology grants worth millions of dollars and leads an active team of clinical researchers at Peter Mack. He holds senior editorial positions at the BJUI, European Urology, Nature Reviews Urology, and Prostate Cancer and Prostatic Disease. Not only that, he is also very active on social media with thousands of followers on Twitter and a busy YouTube channel. He also hosts the GUcast podcast, which can be found on Spotify. So we're very pleased to have him join us today to discuss Theranostic PET scans for prostate cancer.
Hello, my name is Declan Murphy, urologist and director of GU oncology here at Peter MacCallum Cancer Centre in Melbourne. I'm very grateful to Professor Ed Chung and Professor Jimmy So for inviting me to speak at this inaugural National University Cancer Institute Surgical Oncology Symposium. Of course, I am sad that I cannot be there with you in person, but I do congratulate you on putting together this terrific program during the pandemic. I have visited you in Singapore many times in the past, including grand rounds at NUHS 3 years ago with my son. And let me tell you, Singapore is top of our list of destinations for a family holiday once we are allowed to travel again. And indeed, we look forward to warmly welcoming you, our Singaporean friends, back to Australia again as soon as we possibly can. So today, I am very pleased to speak to you about these two really hot topics in prostate cancer today: PSMA imaging and PSMA Theranostics. Our team here has really focused a lot of effort in these areas over the past 7 or 8 years, and it's good to see some of our research now come to fruition. And I think for anyone working in the field of prostate cancer, some knowledge of PSMA is absolutely essential, and I'll do my best to give you some updates today. Coming up first, we'll focus on PSMA imaging, in particular the role of PSMA for staging newly diagnosed prostate cancer. Second, we'll move on and talk about PSMA Theranostics, including the future directions in this very exciting area. But first, let's quickly look back at the PSMA story and how we got here. Now, as many of you already know, the PSMA molecule is overexpressed in prostate cancer, especially in aggressive stages such as castration-resistant prostate cancer. This has been known for many years, but it is only in more recent years that small molecule ligands targeting the extracellular component of the PSMA molecule have been developed and have demonstrated extraordinary utility for imaging prostate cancer, especially when compared with conventional imaging. Here at Peter Mack in Melbourne, we have had extensive experience using PSMA PET-CT since 2014. Our cancer centre has considerable expertise in PET imaging, performing more than 12,000 scans per year, very many of which are part of ongoing research trials. We currently have 4 PET-CT systems and a number of gamma cameras for SPECT-CT, in addition to conventional CT and MRI systems. We have a cyclotron on site, 2 hot labs and a very experienced radiopharmacy team. Our uptake rooms have great views of the city, creating a nice environment for our patients. We also have a purpose-built Theranostic suite to allow the delivery of radioligand therapies such as lutetium PSMA. The first data on small molecule ligands targeting PSMA emerged from Heidelberg in 2013. We were very interested when we saw these first images, and we performed our first gallium-68 PSMA scan in 2014. This is our first patient, a 65-year-old gentleman with high-risk prostate cancer scheduled for prostatectomy. Conventional imaging showed no regional or distant disease, but his PET scan was quite a revelation. Not only were we struck by the incredible avidity seen within the primary itself, but also by the additional findings including a pelvic lymph node and what appeared to be a rib metastasis, neither of which we saw on conventional imaging. We didn't want to change our plan based on a brand new scan, so we proceeded with surgery, and of course the patient had a persistent PSA and the rib metastasis proved to be true. We've never looked back from there and have done very many thousands of these scans since that time. So clearly, for anyone who has any experience using this technology, PSMA PET-CT is an obvious challenger to conventional imaging. The convenience of a one-stop whole-body scan with striking tumour to contrast ratio is certainly compelling. However, striking images alone are not enough evidence to change the way we practice. Therefore, in 2017, we started a randomised trial, the ProPSA Trial, to compare PSMA PET-CT with conventional imaging in men with newly diagnosed high-risk or unfavourable intermediate-risk prostate cancer. The results of ProPSA were published last year in The Lancet. The primary endpoint was accuracy. We randomised 302 men to undergo either CT and bone scan or PSMA PET-CT as first-line imaging, and then cross over to undergo second-line imaging with the other modality. The patient characteristics are summarised here, most typical of a population at risk of regional or distant disease. So what did we find? Well, we reported that PSMA PET-CT is 27% more accurate than conventional imaging, with PSMA correctly staging 92% of patients compared with only 65% of patients with conventional imaging. And some of these secondary endpoints are also important. Management impact was profound, with PSMA leading to management change in more than 1/4 of patients. Equivocal studies were seen in 23% of conventional scans, but in only 7% of PSMA scans. And radiation dose was less than half in men undergoing PET-CT compared with CT and bone scan. And in a pre-planned health economic analysis, we clearly showed that novel imaging is more cost-effective, even in an expensive country like Australia. I also strongly believe that there may be a strong health economic argument to support PSMA PET-CT in Singapore for this patient population also. Now that's all well and good, but PSMA PET-CT is a disruptive technology and has revealed some important uncertainties which remain to be determined, many of which involve management impact. In particular, how do we know that the decisions we make based on PSMA PET-CT lead to improved outcomes for our prostate cancer patients? Let's consider two scenarios. First, does the knowledge of lymph node status help with surgical or radiation planning, and does this improve outcomes? PSMA PET-CT has high specificity for lymph node disease, so certainly if pelvic nodes are present on a scan, one can presume they will be positive on histopathology, and therefore a thorough lymph node dissection or pelvic nodal radiation can be planned. However, the sensitivity of PSMA for lymph node disease is obviously determined by the size of any deposit, and no PSMA tracer, nor any imaging modality for that matter, will ever reliably detect lymph nodes with less than 3 mm involvement. But does this really matter? Does a negative PSMA PET-CT mean that a pelvic lymph node dissection can be avoided? Well, I can tell you that in real-world practice, a negative PSMA scan certainly does influence that decision, and in very many patients we avoid pelvic lymph node dissection. But is this a good or a bad thing? I think we should acknowledge that lymph node dissection remains a contentious topic, and we should remind ourselves that lymph node dissection does not improve survival and does increase morbidity. This excellent systematic review in European Urology nicely summarises this, emphasising that pelvic lymph node dissection does not improve cancer outcomes and does lead to increased complications. So PSMA has not answered the question of what to do about lymph nodes in high-risk prostate cancer. It may actually have increased the uncertainty. Second, does the knowledge of distant disease not apparent on conventional imaging save patients from futile local therapy? Well, here's a 46-year-old patient of mine from the ProPSA study who was N0 and M0 on conventional imaging and would clearly be offered local treatment with curative intent. However, his PSMA PET-CT reveals extensive retroperitoneal lymphadenopathy, thereby making him M1A. What do we do now? If we follow the conventional imaging, we would obviously offer him local treatment and he would obviously have persistent disease requiring further management. With this knowledge of M1A disease, should he instead have maximum systemic therapy plus maybe radiotherapy to the primary, as he is low volume by the hybrid criteria we tend to use? Well, this is actually what he has opted for, and he is doing very well 4 years later at the moment. Now, on the one hand, one can say that the management impact of PSMA here led to the patient having appropriate management of metastatic disease, and that PSMA saved him from futile local treatment. However, on the other hand, one can argue that perhaps we do a disservice to such patients who are M0 on conventional imaging by denying them local treatment. Whatever one's feelings on this, PSMA causes disruption and uncertainty and actually poses new research questions such as what is the role of local therapy in metastatic disease evident only on PET scanning? Now there is a counter-argument to be made to this last case because much is made of the increased sensitivity of PSMA for detecting disease not apparent on conventional imaging, thereby leading to stage migration and altered decision making. But as we showed in the ProPSA trial, PSA is also more specific than conventional imaging, correcting the false positives which we all too often see. We wrote about this in the JCO and I shared an example of a patient of ours who had a well-characterized bone metastasis on 3 forms of conventional imaging, CT, bone scan and MRI, who was planned for systemic treatment. However, we did a PET scan which demonstrated avidity in the primary but no avidity in the bone. We therefore correctly recharacterized this as a bone island and proceeded to radical prostatectomy with an excellent oncological outcome. ProPSA reported equivocal findings in 23% of patients undergoing conventional imaging, so this is not a rare situation. And the message is PSMA has much greater accuracy than conventional imaging. And if you and your patients value having accurate staging of your newly diagnosed patient, then PSMA PET-CT is the best technology to do this. But the sum of all this is we still do not know if the decisions we make based on this superior accuracy are improving the survival of our patients or the quality of life of our patients. And it would take 10 plus years for such endpoints to mature. We therefore must rely on multidisciplinary consensus while data is emerging so we can do the best for our patients based on what we have already. Nonetheless, we recommend that PSMA PET-CT should replace conventional imaging for staging this type of patients. And that's certainly our practice in Australia today. So how have these results been received around the world? Well, favourably, as we see in the EAU guidelines updated recently, and also in the recent FDA approvals in the USA. But a few important concerns remain, the most important of which remains how do we determine that the management decisions we make based on PSMA PET-CT actually lead to improved outcomes for our patients? Also, does it matter which PSMA ligand we use? Well, let's speak now to my colleague, Professor Michael Hoffman, nuclear medicine physician here at Mack. Michael has led all of our work on PSMA imaging and Theranostics over the past 10 years or so, including our randomized multi-center trials. Michael, we have experience now using a number of these small molecule ligands targeting the PSMA molecule. What are your thoughts on these different tracers?
Yeah, so we have a whole library of PSMA radioligands for imaging. The first one being gallium PSMA 11, but also in widespread use now is 2 fluorinated compounds, DCF-PYL and PSMA 1007. And I have experience with all 3 agents and I think they are all outstanding and whichever you can get your hands on will be good for your patients. There are some minor differences between these molecules and us as nuclear medicine specialists need to be aware of these as we review and report the scans. But I think for our referring oncologists, you can consider them all bioequivalent and no doubt there'll be even a greater library over time. And this is great for our patients because competition brings costs down and in different jurisdictions there may be preference for one over the other, but let me assure you they're all outstanding.
Well, thank you very much, Michael, and congratulations again on all the work you do in this area. So our final topic to cover on imaging is what's next for PSMA PET-CT. Well, here are a few areas that we are interested in. First, is there a role for PSMA PET-CT in the early detection of prostate cancer? Now, I know you have all very much embraced MRI at the top of your diagnostic paradigm in men suspected of prostate cancer, but MRI is not perfect, and we wonder whether PSMA PET-CT might have a role to play in this setting. We have just published the primary study in European Urology, a single-arm multi-center study of PSMA PET-CT limited to the pelvis only in 296 men who had already undergone a multiparametric MRI and were planned for transperineal biopsy. The objective was to determine if PET scanning adds value when compared to MRI in the detection of significant prostate cancer. Here you see an example of a patient in the primary study with a normal MRI but a highly avid lesion on PET scanning. On biopsy, this was confirmed to be grade group 3 cancer. In this study, we report that the combination of PSMA and MRI improved the sensitivity and the negative predictive value compared to MRI alone. Significant prostate cancer was present in 28% of PIRADS 2 and 47% of PIRADS 3 patients in whom PSMA PETCT was positive in 90% of cases. This prospective data in favour of the addition of PSMA to MRI, especially in the PIRADS 2 and 3 patients, has led us to design a randomised trial of PSMA PET in early detection, which will open in Australia later this year. What about pelvic lymph node dissection? Can we use PSMA-based technology to enhance the way we do pelvic lymph node dissection?
Yes is the answer. Radio-guided surgery using PSMA is one of our most exciting areas of research. Can we improve the performance of pelvic lymph node dissection while reducing the morbidity by using a PSMA radio-guided surgery approach?
The utility of this has already been demonstrated by our German colleagues using an open surgical approach. Patients are injected with indium-labeled PSMA the day before surgery, and a gamma probe is used intraoperatively and ex vivo to detect lymph node metastases. With recent FDA and CE mark approval of a novel drop-in gamma probe from Lightpoint Medical, we can now evaluate radio-guided surgery using a robot-assisted approach. We have developed a protocol for this and plan to open this study at Peter Mack later this year, extending to an international multi-centre trial next year. So that covers our first section on imaging using PSMA PET-CT. The key messages are that first, PSMA PET-CT has superior accuracy for the primary staging of prostate cancer when compared with conventional imaging, with less radiation, less equivocal findings, big management impact and better cost effectiveness. Therefore, it should replace conventional imaging where possible. And although I have not covered PSMA PET for biochemical recurrence today, this has also become standard of care indication for PSMA PET-CT. And I've shown you PSMA is also under evaluation in other settings. Now let's move on and talk about PSMA Theranostics. We've talked about the value of the PSMA molecule as an imaging target, and now we extend to consider the value of the PSMA molecule as a therapeutic target, an area of practice called Theranostics, and truly one of the most exciting prospects in the treatment of prostate cancer today. Coming up, first, a brief explanation of what we mean by PSMA Theranostics. Then, a look at our initial experience of lutetium PSMA for men with very advanced prostate cancer. We shall also look at the recently published randomized data comparing lutetium with other standards of care. And finally, a look ahead to where we are going next with this type of treatment and why it matters to not just medical oncologists, but also to radiation oncologists and to us urologists. Earlier, we discussed the PSMA molecule and highlighted how it is overexpressed in prostate cancer, especially advanced prostate cancer. We showed you how we can use small molecule ligands targeting the PSMA molecule to produce incredible images using PET-CT technology, and how this high value of PSMA PET-CT for diagnosis is superior to conventional imaging. PSMA Theranostics takes the high utility of PSMA as a diagnostic target and exploits a therapeutic opportunity. We can explain this as follows. Here you see a PSMA PET-CT of one of our patients with mCRPC having exhausted all lines of therapy. Overexpression of the PSMA molecule in his extensive bone and visceral metastases means that we can visualize these using a diagnostic PET-CT with PSMA. However, we can also target the overexpressed PSMA molecule by combining a PSMA ligand with a small radioactive molecule such as the beta emitter lutetium-177. This therefore is a highly selective form of targeted intravenous radiotherapy, as essentially the lutetium will be delivered to the most prominent sites of disease with most overexpression of the PSMA molecule. This approach was first described in a case report from Germany in 2015 with these very striking images. It caught our attention and we therefore set up a prospective phase 2 study to evaluate the safety and efficacy of lutetium in men with progressive mCRPC who had exhausted all other options. We published this in Lancet Oncology in 2018 and updated it subsequently. This was the world's first prospective experience of lutetium PSMA, and I'd like to talk you through this series today as it has certainly proved to be very interesting and has led to the pivotal randomized trials recently published. In this trial, we enrolled men with progressive mCRPC who really had run out of options and offered them up to 4 cycles of lutetium we excluded patients with low PSMA expression or discordant disease on FDG, leaving 50 patients who we included in this analysis. We discontinued therapy in 10 patients with progressive disease, in 2 patients with marrow failure, and in 8 interesting patients who proved to be exceptional responders. The patient characteristics are summarised here, typical of a very advanced prostate cancer population, with a mean PSA of 190 at study entry and a doubling time of just over 2 months. 87% of patients had received first-line chemo, including almost half of patients who had received second-line chemo. More than 90% of patients had received ABI or ENZA. We carefully measured the dosimetry using SPECT-CT in all patients receiving lutetium in our trials and have published details of this separately. You will see here, for example, that high-volume, highly avid metastatic lesions in the adrenals and the pelvis receive very high doses of radiotherapy, but very little else is delivered to areas with lower PSMA expression, such as the salivary glands and the kidneys. The co-primary endpoints of this study was safety, and we have published details of this in our manuscripts. But in summary, I can tell you that this day-case therapy is extremely well tolerated with very few serious adverse effects. In fact, it is very typical for me to hear from my patients on these trials that of all the various therapies that they have received over the years for their metastatic cancer, lutetium is by far the one which causes them the least issues. The other primary endpoint was best PSA response, and you can see here that we really had very encouraging data with more than 2/3 of patients having a greater than 50% reduction in PSA. When one considers that these men have exhausted all other options at study entry with a mean PSA of 190 and a doubling time of 2 months, there certainly seems to be significant oncological benefit here. We are now showing you 8 of our exceptional responders who discontinued treatment due to a complete molecular imaging response following their initial 2 cycles of lutetium PSMA. In each panel you can see the before and after MIP images of these patients with clearly some quite dramatic improvements. You can also see the significant reduction in PSA under each image. But inevitably, almost all the men in this study did eventually progress, and the mean overall survival was 13.5 months. Now, I mentioned earlier that we use both PSMA and FDG PET when selecting patients for lutetium, and I want to expand on that a little as it does provoke some discussion. For example, this is a patient referred for lutetium PSMA at our centre, whose PSMA PET clearly shows lots of PSMA avid disease. Is he suitable for lutetium PSMA? Well, you might say yes, but when we do an FDG PET, we see more. We see something different. We now see additional FDG avid liver metastases and bone metastases without corresponding PSMA avidity. We call this discordant disease, and our view is these patients are not good candidates for PSMA. We exclude them from our studies and have published details of this in European Urology Oncology, noting the very poor survival of just over 2 months in those men we excluded. We concluded from our phase 2 study that in men with progressive mCRPC who have exhausted all other options, lutetium PSMA has a high response rate with limited toxicity and significant improvements in pain and well-being. Therefore, unsurprisingly, within a few months of us delivering our first lutetium back in 2015, having seen some amazing responses, we started planning a multi-centre randomised trial. This trial, the Therapeutic trial, was presented at the ASCO GU meeting earlier this year by my colleague Professor Michael Hoffman, with the full manuscript published in The Lancet simultaneously. Men with progressive mCRPC following docetaxel being considered for second-line chemo with cabazitaxel were eligible for this trial. Patients had to have PSMA-avid disease with an SUV max of greater than 20 and no evidence of discordant disease on FDG PET. 200 patients were enrolled and randomized in a 1-to-1 fashion to receive either cabazitaxel or 6 cycles of lutetium. These waterfall plots display the primary endpoint of PSA response of greater than 50%. Patients receiving lutetium had a 66% response rate compared with only 37% response in those receiving chemo, a hazard ratio of 0.71 in favour of lutetium. These patients also had improved progression-free survival compared with cabazitaxel and an improved objective response rate in favour of lutetium. And of course, as expected, patients receiving chemotherapy experienced significantly more grade 3 and 4 adverse events compared with those receiving lutetium PSMA. This trial is important as it represents the first randomized study to compare lutetium with standard of care active treatment for men with mCRPC, and it demonstrates superior PSA response, improved PFS and or when compared with cabazitaxel, plus less adverse events in favour of lutetium. And therefore we conclude from this study that lutetium PSMA represents a new class of effective therapy for men with progressive mCRPC. However, the Therapeutic trial has not yet reported an overall survival benefit, but this is a secondary endpoint which will be reported in due course. Now, there is a second randomized trial, the VISION trial, which has also recently reported and which did report overall survival as its primary endpoint. The VISION trial was presented at the ASCO meeting in June this year and was published in the New England Journal of Medicine a few weeks ago. This multi-center randomized study also enrolled men with mCRPC who had progressed following both docetaxel and AR pathway inhibitors, and randomized them to have ongoing standard of care treatment or to receive 4 to 6 cycles of lutetium PSMA. The co-primary endpoints were met, with image-based progression-free survival improved by 60% in those men receiving lutetium. Men receiving standard of care had a median PFS of 3.4 months compared with 8.7 months in the lutetium arm. The other co-primary endpoint was overall survival, which was also significantly improved by 38% in those men receiving lutetium PSMA. The median OS in the standard of care arm was 11.3 months compared with 15.3 months in the lutetium arm. And all the key secondary endpoints also favoured lutetium. The incidence of adverse events of grade 3 or above was higher with lutetium than without, but the quality of life was not adversely affected. Now, there are a few important differences between VISION and therapy, which I would like to highlight. First, VISION selected patients based on PSMA PET alone, simply requiring at least one site of PSMA disease and no large sites of PSMA negative disease. And at screening, 87% of patients were deemed eligible based on PSMA PET. And with such a high positivity rate, it led to a comment in the discussion at ASCO about whether a PET scan is even required for selection. Whereas in therapy and in our other theranostic studies at Mack, we continue to use both FDG and PSMA to optimally select patients. However, I think we must accept that VISION has shown us that there is an OS for a significant number of patients based on just using PSMA alone to select patients. Second, there has been a lot of discussion regarding the control arm in VISION, as patients in this arm were not allowed to have cabazitaxel or radium, both with established survival benefits in this population. The reason the authors state for this is that lutetium had not been tested in combination with these compounds at the time, and therefore safety could not be assured. The authors also argue that patients were only eligible for the trial if clinicians advised that chemo was not recommended, although almost 1/3 of patients did actually go on to receive chemo on progression. But of course, in the therapy study, the active comparator was cabazitaxel. So I think by considering both trials together, we can certainly say that lutetium PSMA should now be considered a standard of care option for men with mCRPC who have progressed following docetaxel and AR pathway inhibitors. And if you want to hear more about this, our podcast, GUcast, has dedicated a few episodes to really exploring PSMA Theranostics in great detail with the key investigators. Just grab this QR code or search GUcast in all your usual podcast platforms and you can find some entertaining episodes on this topic. So this is now really big news, but of course there are barriers to rolling it out around the world depending on regulatory environments for radiopharmaceuticals and of course reimbursement. But we certainly look forward nonetheless to increasing availability and interest based on these studies. Finally then, let's consider what's next for radioligand therapy in prostate cancer. At MacCallum Cancer Centre, we have a large portfolio of ongoing prospective trials in PSMA imaging and theranostics. We recently fully recruited our 2 phase 1 trials of lutetium combined with olaparib and pembrolizumab, the LUPARP and PRINCE trials respectively, in men with progressive mCRPC. My colleague, Associate Professor Shaneen Sandhu, is leading these trials, and we look forward to seeing results from the PRINCE trial at ESMO this year. We also have 2 trials to evaluate lutetium PSMA in less advanced stages of prostate cancer, which I think clinicians in Singapore might be interested in. The first of these is the Upfront PSMA study for men with de novo metastatic hormone-sensitive prostate cancer. In other words, very much the sort of patient we urologists diagnose. This is a multi-center phase 2 randomized study comparing ADT and docetaxel as standard of care with ADT, docetaxel and up to 6 cycles of lutetium PSMA. The objective is to see if the addition of lutetium to standard of care in this much earlier form of metastatic prostate cancer might improve outcomes for our patients. Upfront PSMA opened in the middle of the pandemic last year and is recruiting very well, having enrolled more than half its participants. And the other study, which I think urologists in particular might be interested in, is the Luteectomy Trial. We all know that men with high risk, apparently localized prostate cancer have high rates of biochemical failure following surgery or radiation alone, and unfortunately no neoadjuvant strategy to date has been shown to improve outcomes for these patients. We therefore designed this phase 1-2 study to evaluate lutetium PSMA prior to radical prostatectomy in men with high-risk prostate cancer and high SUV max on PSMA. I am the primary investigator on this study, which also opened during the pandemic, but is recruiting well ahead of expectation, having recently just passed the halfway point. The primary endpoint is dosimetry, with key secondary endpoints including safety and various oncological outcomes. And I can tell you that we are very encouraged by our early experience with these patients. Here's a typical example of a 57-year-old with locally advanced prostate cancer, PSA 38, grade group 5, PIRADS 5 lesion, node positive on PSMA PET, with a high SUV max of 47. He received a single cycle of lutetium 6 weeks prior to surgery and had an almost complete response in his bulky external iliac lymph nodes. I can tell you that surgery in these cases is extremely straightforward, with no treatment effect in any cases so far, and maybe even an improvement in operability. We look forward to presenting data from this study next year. So that's it, ladies and gentlemen. I do hope that you found this topic of PSMA imaging and theranostics to be of interest. To me, these have certainly been very interesting areas of research to be involved with over the past 6 or 7 years, and I think the next 6 or 7 years will be extraordinarily exciting indeed. I know that clinicians and patients in Singapore are already gaining experience of PSMA imaging and theranostics, and hopefully we can work together to advance this field and provide even better options for our patients in the future. Thank you again for the invitation.
Thank you very much, Professor Murphy, for that really nice talk. We actually have got a couple of questions from the audience, and it is from Professor Edmund Cheong, who is the head of our urology unit in NUH. And so his questions are actually for primary staging with PSMA PETCT that shows small oligometastatic disease, which is negative on conventional imaging. Do you treat it as metastatic disease or high-risk localized disease, as the treatment modalities for those are actually very different?
Well, thank you very much. Thank you again for the invitation to speak to you, and thank you to Ed for that question. Well, I'm afraid he's just identified one of the great modern day challenges as we try to incorporate PET imaging into daily practice. What do we do in these situations? I can tell you that it's very unclear what to do, so we tend to apply other external factors such as what is the age and fitness of the patient, what is the extent of disease, what's the location of disease. And for example, in a younger, fitter patient with low volume disease, not evident on PET imaging, we will often offer them the benefit of the doubt. In other words, we'll still offer curative intent local treatment. However, our conversation with the patient is certainly enhanced by the fact that we were able to say the patient's unlikely to be cured because we can see this low volume disease outside the prostate. And therefore the conversation about multimodal approach becomes even more important for these high risk so-called localized prostate cancers. Whereas on the other hand, if you have a patient who is borderline fit or other comorbidities and so on, in whom you are already anxious about offering local treatment, certainly surgery, then it may tip you more towards systemic treatment, perhaps consolidated by radiotherapy to the primary. Because one of the things that recent trials have shown us is that we can manage these low volume patients by using radiotherapy to the primary. And I think that's where our conversation pushes either benefit of the doubt, go for it with multimodal approach, or push over towards a more conventional oligometastatic approach using radiotherapy to the primary. I hope that answer helps, Ed, but you know the truth is this is the classic conundrum that we face now with PET imaging.
He says he agrees with that answer. He also has a second question. Is there a role to avoid pelvic lymph node dissection during radical prostatectomy for high-risk cancers when the PSMA PETCT staging is negative for METs in the lymph nodes?
Yes, and this is another great conundrum of PET imaging in contemporary practice. And we highlighted that a little bit in the discussion because I think that question is one of the great questions we face. So I'll tell you what happens here in Australia very, very often in a patient who's had a PET scan with negative, no evidence of disease in lymph nodes. We avoid a pelvic lymph node dissection compared to what we used to do years ago when very, very many of these patients had a lymph node dissection. So we tend to offer patients the option. And what I mentioned in my talk, things like lymph node dissection does not improve survival, lymph node dissection does increase morbidity, are really important in the way we counsel patients. And so, for example, if we use a nomogram to predict the likelihood that this patient will have lymph node involvement under the microscope. So, for example, we might find that 12% likelihood that this particular, so therefore this 88% of these patients would have a full lymph node dissection and no cancer on the thing, to find the 12% who don't have a survival benefit. So let me tell you, Ed, I think our practice, right or wrong, has certainly shifted away from just blind lymph node dissection when there's no evidence of disease on a PET scan in favor of early re-PET scanning and early salvage radiation or even surgery for those lymph nodes if and when they do recur in that very small number of patients. So the answer is, it's certainly, I can tell you, real world practice has driven down the rates of pelvic lymph node dissection.
So thanks very much. There actually is a question from the audience, Professor Jimmy So.
Thanks. Thanks, Declan. Excellent talk, Jimmy So. And my talk is on the development of PSMA isotope scan. Years ago, we tried to develop something similar to improve the imaging for peritoneal metastasis. And when we talk to our nuclear medicine colleagues, that they say that to develop a new isotope other than FDG for a PET scan is actually a daunting task, and it's also a very expensive adventure. So how's your PSMA isotope scan developments? What's your experience on that?
And thank you, Professor So, and congratulations again on this excellent symposium. You know what, I think one of the great things that PSMA has taught the nuclear medicine community is that it is possible to break the stranglehold and develop these tracers into other disease areas where FDG is not most dominant. So FDG has been very safely commercialized, it has GMP criteria, it can be made and shipped out to all the hospitals, and other tracers have not been successfully developed for much of the same reasons that your colleagues mentioned. However, prostate cancer, big common cancer in many regions, creates this new opportunity. And if you have a tracer like PSMA that is successful in a big disease area like prostate cancer, let me tell you, the supply chains will develop, the commercialization models will develop, the local radiopharmacy expertise will develop, and so on and so forth. And I think that it's clearly here now for PSMA. It's not a problem in many countries, although reimbursement may still be an issue. And we can probably learn from that in other cancer areas, maybe even like peritoneal cancer or other less common cancers. And if we say to the nuke med community, look, work hard on this area, look how it happened in prostate cancer, this is also a common cancer, please put all your talent into looking at options here. So I actually think that the really big breakthrough where now so many nuke med departments are getting ready to do PSMA may also benefit the development of other fabulous molecular imaging agents in the future.
Thank you very much, Professor. I think that we should be wrapping up this first talk already. Thank you so much for excellent perspective on the future of staging as well as treatment for prostate cancer.
Thank you. Good day from Melbourne.